the arms do not get stuck by the hand. God have created them with a wider carrying angle. Okay. Now, what is the definition of a varus and a valgus? So, in a cubitus varus, it is a condition where the forearm is directed towards the midline. So, this is your forearm and it will be directed towards the midline. So, the angle becomes negative, low. It can be less, it should be actually less than 0 degree, but normally we don't see rectus a lot and we don't use the word rectus a lot. If it is less than 5 degree, we tend to call them a varus deformity. And what is a valgus? It is a condition where the forearm is directed away from the midline. Now, usually it is away from the midline, but if it is more away, that is the angle is more than 15 degree, then that is an abnormal condition. And that can lead to problems also. What problems I will come to later. So, that is called a cubitus valgus deformity. So, what is a cubitus varus? Now, these are the synonyms, very important. You have to know something called the bow elbow or a gunstock deformity. So, it will look just like this. So, you have to know these terms because these are very common. And the most common cause is a malunion of a supracondylar fracture. Now, again, supracondylar fracture is very important for your MBBS exams. Okay. So, supracondylar class hoye gache to. Supracondylar fracture most common. Now, cubitus varus, whatever you see is a more common deformity than a cubitus valgus deformity. And the most common cause causing a varus deformity is a malunited supracondylar fracture. So, what it can cause? Other causes is osteonecrosis. Now, you have to understand, supracondylar fracture it is causing like this deformity. That means what? The lateral part is growing more, the medial part is growing less. Only then, if the lateral part is growing more, then only it can rotate a elbow like that. So, osteonecrosis osteonecrosis or AVN, avascular necrosis it can happen in certain trauma and it's usually associated with the medial condyle. If there is a medial condyle necrosis, then the medial condyle won't grow, the lateral condyle will grow, that will cause this kind of deformity. So, that is another cause. Okay. And there can be some growth disturbances can be seen in rickets also. So, these are 2-3 causes that you should know. One is supracondylar fracture, another is avascular necrosis of the medial condyle, 3 is traumatic disturbances, growth disturbances, 4 is rickets. So, 4 causes more than enough for your exam, no need to know more than that. Now, causes of malunion. So, this has been already been discussed in supracondylar humerus topic, that what are the patterns of the deformity, medial displacement, medial tilt, that have already been discussed. It is a 3-planar deformity. If the supracondylar fracture doesn't unite, it is a 3-dimensional and a 3-planar deformity. Okay. So, in the supracondylar humerus, when I told that you can see what happened, there will be hyperextension. If there is a deformity, if it is a malunited supracondylar, there will be a hyperextension, there will be restricted flexion. If you compare with the other elbow, this elbow will come to this, but this elbow won't come like that. And there will be a varus deformity. So, there is an hyperextension, there is an internal rotation, and there is a varus deformity. So, supracondylar malunion is always a 3-planar deformities. There are 3 deformities that are happening together in one plane. Okay. So, varus deformity, this is how an picture might come for your exam. This is a classical gunstock deformity. So, it will just be like that. So, when you ask the patient, so always this deformities has to be seen with the elbow extended. You cannot see with the elbow flexed. When you flex the elbow, these deformities will disappear. You cannot see them. So, only if you extend the elbow, then only you can see those deformities. Now, this is a child with the elbow extended and sitting like this. And then what you can see is a classical gunstock deformity. And this deformity, see, it is mentioned on extension of the elbow. So, this is most important. You cannot see it in the flexion of the elbow. You have to always extend the elbow. Then only you can measure the carrying angle. Then only you can make it out whether it is a varus deformity or a valgus deformity. Now, varus deformity is important to know that this is mainly a cosmetic deformity. It is not going to cause any major problem. It is not going to progress. It is a static deformity. Now, if a supracondylar malunited supracondylar fracture has come to you after 6 months, you will see that it is only 10 degrees, but the child is only 4 years old. And the parents are worried. Then you have to counsel the patients that, see, this is a static deformity. If your carrying angle has become minus 10 degrees, it is going to stay at minus 10 degree even after 6 years. 4 years is too low to correct that deformity, because you can correct it only by a surgical procedure, and 4 years is not the ideal time to do the surgery. So that you have to counsel the parents that, see, it is a cosmetic deformity. He is not going to have much problem. He can flex the elbow, maybe last 10-20 degrees is not going to come. It is not going to give him any pain. It is just going to look bad when he is extending the elbow. That's all is going to happen. It is not going to cause pain. He can do every work, but if you want to correct it, this is not the right age to correct it. You can correct it once he attains 10 or 12 years of age, because you have to understand that all the physes around the elbow are still open, and by doing any osteotomy or cutting it, if you injure any of them, then you are going to land up in more trouble. Okay, so this is how you should counsel. Now, because this kind of deformities are very common in the general orthopedic practice, so this kind of patients, they will go to a traditional bone setter in the village. Wherever they find, they will do a cast, or they won't go for any treatment, and they will come after 6 months saying that the arm is now bent. So this is important to know, that a cubitus varus deformity coming out of a supracondylar is just a cosmetic deformity. It is a static deformity. That is second important point. It is not going to progress. And the third point, what is that? It is not going to correct by itself. You have to do some kind of surgery. Okay. So what are the important things? So this is a cosmetic problem. There is no functional disability. He can actually do everything. Only the terminal 10-20 degrees of flexion is not going to come. But if you see your elbow, you can do all your work by even 0 to 90 degree of flexion. The rest 30 degree is extra. You don't need that to do your daily work. Okay. And what can happen? There can be an ulnar nerve irritation and neuropathy who present very late, because you have to understand this. The ulnar nerve goes behind the medial epicondyle, and when your elbow is bent either this way or this way, it is going to stretch your nerve behind the medial epicondyle. Now, ulnar nerve stretching is not much common in varus deformity, but it is very, very much common in the valgus deformity, classically giving rise to a term which you have read in anatomy, which is called the tardy ulnar nerve palsy. Okay. এটা তোরা ফার্স্ট ইয়ারে পড়েছিস কিনা জানি না, নিশ্চয়ই ছিল, তো শর্ট নোট আসতো না, tardy ulnar nerve palsy. So that kind of thing is more common in a valgus deformity, not that much common in a varus deformity. It can happen in certain cases because of overstretching, but it is very rare. Mainly what can happen in a varus deformity is, it is a cosmetic problem that will look ugly to the eye. That's all. It is not going to cause much problem. So that is what, because you can even see many people 25-30 years, if you ask them to stretch the hand, they will have this gunstock deformity, and they are doing nicely work. They don't have any issues at all. So there are many people around who will still have a bent elbow, but they won't complain anything. So they are doing absolutely fine, and those are the cases of a cubitus varus deformity. So this is again how they have radiologically. So if you see at the X-rays on the second X-ray, if you see, this is what has caused the malunited supracondylar fracture. And if you see this X-ray, that is where they have marked out. Now, these X-rays are needed because when you are planning for an corrective osteotomy, you have to make a point. So we have a surgery called the French osteotomy. So it is not because it was discovered in France, but its name is French osteotomy because the surgeon who described that was a French orthopedician. So that's why it became a French osteotomy, and it was discussed way back around somewhere in 1800s, I feel. I am not sure of the date. So what he said, that you have to correct the three-planar deformity, and for that you have to find the cora. Cora means the center of rotation of axis. So you have to find where the two lines join of the deformity, and that point has to be the center where you cut the bone and then you rotate the bone. Unless you rotate that at that point, you are not going to correct the deformity. And if you are going to cut at any other point, you are not going to correct it. You are going to create more deformity. Okay. So what are the treatment options? See, that's what I said. It has no tendency for spontaneous correction by remodeling. It is not going to correct by itself. The surgeon has to intervene. You have to correct the deformity by making an osteotomy and then correct it. It is not going to correct on itself. So that is absolutely important, and that you have to explain to the patient that, see, it is not going to correct by itself. It is going to stay like that, but it is only a cosmetic problem. It is not going to cause any functional problem. If you are happy, all is okay. But if you wanted to correct it, then I have to do a surgery to correct it. Okay. So see, again it is mostly done for cosmetic reasons. It is just because it is looking bad. It is not because the patient cannot do anything or it is going to cause any other issues. Okay. So what are the options that are available? So hemi-epiphysiodesis. So what is hemi-epiphysiodesis? Now you have to know that the elbow has two physes, medial and lateral, and in the previous class I have told you how the physis closes. If you remember the mnemonics CRMTOL, I said 2, 4, 6, 8, 10, 12, that are the mnemonics. So what is hemi-epiphysiodesis? Epiphysis means the growing points, desis means you close that growing point, and hemi means you close it on one side. Okay. So in a varus deformity, you are creating this kind of gun stock. That means this side has grown more, this side has grown less. So what you need to do, you have to stop the growth at this point. So when you stop growth at this point, this side is again going to grow, and then you are going to get a straight elbow. So that is what you mean by a hemi, that means half. Epiphysis means the growing point, and desis means closing. So you have to close the other half of the growing point which is growing. So when that stops and this continues to grow, then you are going to get back a normal elbow. But this is not done nowadays. This is a very primitive procedure, but just for the sake of completion, you guys have to know it. So this is something called hemi-epiphysiodesis, and that is how you get a growth alteration. Okay. See, it is written in patients with medial growth arrest and progressive deformity. This is the medial growth arrest and progressive deformity. That means what? It is growing like this because the lateral part is growing more. So you have to close the growth at the lateral point. Then only you may correct it gradually. Otherwise, you are not going to do. But most importantly, what is done is a corrective osteotomy. That was I was telling. And the most commonly done corrective osteotomy for a varus deformity is a French osteotomy and a modified French osteotomy. Just remember these two names. Components you may remember, but that is not that important. But you have to know the name of the osteotomy. One is French osteotomy, another is a modified French osteotomy. Okay. And third thing is a distraction histogenesis by Elizarov technique. So the corrective osteotomy, that what was calling the French osteotomy. So this is a lateral closing wedge osteotomy. What is a lateral closing wedge? I will show you in the picture. There is again a medial opening wedge osteotomy. So what happens, you have to understand this. It is like this. So that means, unless I have a paper, I cannot show. And osteotomy marking is just like doing mathematics. It is everything geometry. So you have to correct the deformity. So the thing is, now if you see the marker, now you are telling that suppose consider it to this elbow. Okay, this is the normal valgus. This is my right elbow. Okay, this is your humerus, this is your forearm. So normal valgus. Okay. So what happens in a cubitus varus? It will become like this, right? It will become like this. So it is becoming like this. Now what is a lateral closing wedge osteotomy? Now you have to understand. Now I have to make this straight. Okay. I have to make this straight, or I have to make it valgus. So what you have to do? You have to make one cut like this, another cut like this, and you take that bone out. So when you take that bone out, so when you close this, it is like this. So when you take this bone out, you have taken this kind of bone out, and when you close this, so the entire thing moves out. So it is kind of now suppose, now consider this to this elbow. Okay, this is my humerus, this is my ulnar, this is my radius, and I have a varus deformity. Now this is the medial side. So this is the medial side, this is the lateral side. Now I have to bring this elbow this side. So what do you mean by a lateral closing wedge osteotomy? Is that you have to take this bone out. So you have to make a cut, bone cut. One cut is parallel to this joint, and another cut is the angle that you want to correct. Now suppose I have a varus deformity of -10 degrees and I want to restore it to a normal 5 degree. That means you have to correct it by 10 plus 5, 15 degrees. And that amount of thing you have to take it out. So that is a lot of preoperative. Deformity correction is not an easy job. You have to do long x-rays. You have to sit before the operation, make the cuts. And these cuts, you have to first put K-wires and then you take this bone out. And once you take this bone out, you then shift the entire thing up. Okay. And what will, when you shift this entire thing up, this entire thing will go out. And then you will get a normal valgus. So this is what lateral. So lateral, why? Because you have started from the lateral. Why it is called closing? Because you are closing on the medial side. And why it is called wedge? Because you are taking out a wedge of bone. So this is called a lateral closing wedge osteotomy. So that is how the name came. But I know it is a little bit difficult to understand at your point of age, because unless you see and unless you do it, it is very difficult to understand. So we have something called lateral closing wedge, we have something called medial closing wedge, we have something called chevron. So there are 4 or 5 kinds of osteotomies. But just as for your level, just remember that there is something called lateral closing wedge osteotomy, and that is what is called the French osteotomy. So that is enough for your exam. And just for you understand better, I have told this. So see, they have written step cut, arch, pentalateral, oblique osteotomy. There is something, the oblique arch osteotomy is also called the chevron osteotomy. So there is something called the dome osteotomy. Just remember the names, but for your exam, French osteotomy is absolutely important. So you have to know what is a lateral closing wedge osteotomy, and if you understand better, you will like it more, how it is done, that's what. So see, this is how they have shown. Can you see this now? So you have to understand that the center of rotation has to be first. So this is the axis. This is the axis of the forearm. This is the axis of the humerus. So this is the point. So this is your cora. So your osteotomy should be around that. So that is called the center of rotation of axis. That is called the cora. So your point has to be that. And if you see the lower cut, it has to be done parallel to the joint. See, this cut is made parallel to the joint. Okay. And the next, this angle you have to calculate on the basis of the patient. If the patient is having minus 10 degree, you have to take a 15 if you are going to restore a 5 degree valgus. Now, if it is for females, you have to restore them 9 degree valgus. Otherwise, they cannot keep the hand by the side of the hand. So that depends on the patients, and that is a preoperative planning, and that is how you do it. But the basic thing is that is how you do it. So once you take out that wedge, so then you put that thing up, and then you have to secure that either with K-wires or a plate. If it is you are doing in around 7 to 8 years, K-wires are good enough. If you are doing it in an elderly person, you have to put wires in a figure of 8. So you can put even a plate if you want a sturdier fixation. This is done by Elizarov, so you don't need to know, but the same principle is the same. Lower cut is parallel to the joint, upper cut you measure the angle, what you do, and then you take that bone out, and this is the distraction histogenesis. Distraction means as you distract the bone, new bone will start to form. So what they have done, so they have put a frame over here, 2 frames just for stability, and this is the hinge. So what happens, you have to rotate these screws. So once you rotate these screws, what will happen, this will grow far apart, and as it grows far apart, you have already made a cut, but here you don't remove any bone, because this is Elizarov. Elizarov promotes new bone. This is how you form new bone. You don't take out any bone. So when you make this cut and as you rotate these screws down, so what will happen, this will start growing far apart, and as it grows far apart, it will start forming new bone over here. So and then it will come somewhere like this. It is shown like this, but there will be new bone over here. That is the principle of Elizarov. So that is called distraction histogenesis. As you distract the bone, it will form new bone. So that is the principle of a distraction histogenesis. So that completes Cubitus Varus. Now we come to a more important topic, that is Cubitus Valgus. So where do you find a Cubitus Valgus? So Cubitus Valgus is just the opposite, means extra. Okay. So when do you find this becoming an extra? When there is a medial overgrowth and the lateral is not growing that much. So when the medial is growing this much, your lateral is not growing, it will result in a valgus deformity. So the most common cause is a lateral condyle fracture. Now lateral condyle fracture is the second most common fracture around the elbow after the supracondylar humerus fracture. And the problem with the lateral condyle fracture is it does not unite easily. Now, supracondylar fracture, even if the child is not taking treatment, even if it is fixed in the wrong way, in a bad way, it will unite. Most of the 90 to 95% cases, it will unite. And it is exactly the opposite with the lateral condyle fracture. If it is, now lateral condyle has a classification. Now, if it is displaced by more than 5 mm, and that displacement is even difficult to pick up on X-rays. But if you neglect that, and if the physician or the operating surgeon has mislooked, had not taken a look into it, then it is going to cause a lot of problem, because that is going to land up in a non-union, and that might even result in a avascular necrosis. And then what will happen? It will result in a growth arrest of the lateral condyle, medial condyle will overgrow, and it will result in that deformity. So see, it is the most common cause is the non-union of a lateral condylar fracture. Lateral condyle fracture class other causes are Turner syndrome, Noonan syndrome. These are just for example. Okay. So what is that instrument called where you measure the angle? You have an instrument also to measure the angle. Now you can draw the lines. Now you have to place something, no? You cannot always move around with a protractor. School te amra protractor diye maptam koto angle hoyeche. Now this instrument is called a goniometer. So you have two long scales, and you can just place the scales along the axis, and the middle is the protractor. If you see the middle part, that will show what angle is the carrying angle. This instrument is a goniometer. So cubitus valgus is generally, it is seen in patients with a previous history of trauma to the elbow with a fracture of the lateral condyle. Patient presents with external deformity of the elbow joint, external deformity, and usually asymptomatic till the patients develop tardy ulnar nerve palsy. Now what is tardy ulnar nerve palsy? Now if you go and bend the elbow like this beyond the point, now what will happen? The ulnar nerve that is going behind the medial, it is going to stretch, because it is supposed to go straight. It is not going to take a long route like this. Now if your lateral condyle is not growing, medial condyle is growing, what will happen? Your forearm is going this way, and a nerve has to come here. It cannot say that I am going to still come there. Now if it is going to come there, now it is going to create a pressure point around this area by overstretching, and that is what is known as the tardy ulnar nerve palsy. Patient will have a tingling sensation in the little finger, has paresthesia, numbness, and that is what is called the tardy ulnar nerve palsy. And that is one of the indications to do an operative fixation, and that is an emergency fixation. You cannot delay it. You cannot say that, okay, let the child become 10 years, I will do the surgery. If it happens at 6 years, you have to do that. It is not as emergency like you have to do it within 48 hours, but you have to plan it. Otherwise, it is going to create more axonal damage to the nerve, and you are going to land up in an irreplaceable, because ulnar nerve has a very poor prognosis for a recovery. It is one of the mixed nerve which has a very poor prognostic value. It doesn't recover well. Okay. So what is the cubitus valgus? Tardy ulnar nerve palsy is due to the gradual stretching of the ulnar nerve during the progression of the valgus deformity. Same thing that I said. Symptoms are tingling and paresthesia over the ulnar nerve distribution. So your entire ulnar nerve distribution will be affected. Okay. So what are the investigations? Same, you have to do a plain AP radiograph and lateral elbow, assess the carrying angle, and do nerve conduction studies to see whether the nerve is affected or not for the ulnar nerve. And that is the X-ray how your lateral condyle non-union will be looking like. So that is a classical X-ray. If you see the lateral condyle, it is away and it is not united with the humerus. And that has only happened because of a neglected treatment. This patient didn't get treatment for a lateral condyle fracture in the young age, maybe around 6 to 7 years. And because there are two other physes, there are two separate physes. They are, see, that is how your brain is computed. It is not going to take into effect that, okay, lateral is affected, so medial will grow less. It is not going to go like that. They are all computed in your brain. When you are born, that is computed in your brain, that this is going to grow at this rate, this is going to grow at this rate. So it will not take into factor that, okay, baba, eta kharap hoye geche, tale ami ekটু কম di. That is not going to happen. It is going to grow at its own rate because that is the separate physis. Okay. So the physis for the distal humerus are two separate. Okay. So that is what capitulum and trochlear physis. That are two separate. They are medial lateral condyle physis. So then the lateral condyle physis is affected. It will stop growing because it is already detached from the humerus. It is not going to get any blood supply, and that is why it is showing so lucency. See the rest of the bone, it is hard, white, but see that part of the bone, it has become very fragile, looking blackish, just because it is growing more and more porotic, because it is having less blood supply. It cannot grow, and that is why it becomes like that. So the treatment again is just the opposite. Here you have done lateral closing, so you have to do a medial closing. You just have to understand the deformity. If it is like this, so what you need to do? So there is medial bone growth extra, so you have to take out the medial bone. And generally we try to do a medial type also, because we need to see the, maybe sometimes the tardial nerve also, you have to see the ulnar nerve course also. So that is what important thing. And the name of the osteotomy that you have to remember in this is a Milch osteotomy. Okay. Milch is also known because he also classified the lateral condyle fracture. So that is also known as Milch classifications. Okay. So he was a very popular figure in orthopedics, Milch. So again, the same thing, it has been shown just for you to understand. There is extrus valgus deformity. Now what you have done, they have made a cut and they have put the hinge on the lateral side, and what they are going to do, it's going to separate it more so that it comes in a normal angle. Okay, that's the end of the class.